Good evening, everyone. My name is Dr. Andrew B. Pham. I'm an orthopedic spine surgeon in Washington, D.C. Tonight, I'm going to be giving a talk on innovative treatment options for low and back leg pain. I just want to start by thanking the Gildenhorn Institute of Bone and Joint Health for sponsoring this webinar tonight, and also thanks to Kathy Pulford for helping to organize this. So thank you, everyone, for joining me this evening. And let's get started. We have a lot to go through today. So our objectives of this talk is we want to review the anatomy of the lumbar spine, understand the causes and symptoms of back and leg pain, discuss traditional and non-traditional treatment options, and then describe the common and newer surgical procedures that we offer nowadays. So tonight's goal is hopefully to help you understand your spine, understand your back pain, what causes it, and what can we do for it as clinicians. So to begin, you have back pain. The good news is that you're not alone. 80% of adults in the United States experience low back pain at some point in their lifetime. Nearly 65 million Americans report a recent episode of back pain within the last year. And an estimated 80 million suffer from persistent chronic back pain that lasts for over 3 months. And so it is a very common problem in the United States. And the good news is that 95% of the time, people that have low back pain will not end up requiring surgery. So the vast majority of symptoms can be treated non-operatively. So a little bit more about back pain. Back pain is the sixth most costly condition in the United States, with costs in the United States ranging from approximately $216 billion a year. It's the second most common reported reason for missing work and the number one cause of disability for people less than the age of 45. As the baby boomer generation has gotten older and as our population has gotten older, we've actually seen the prevalence or the new incidence of acute and chronic low back pain increase, and it's actually doubled over the last decade. So obviously a very costly and very prevalent issue that we have here in the United States. Unfortunately, as many people know, it is a difficult thing to treat and to diagnose. Many people suffer with back pain, and you hear a lot of people, and I'm sure you have colleagues and friends who have back pain that just can't be treated. So why is back pain so difficult to treat? First off, there is a multitude of potential causes of back pain that range anywhere from actual fractures and injuries to normal aging processes to stress and mental health issues. And so that's led to an imprecise understanding of the true pathophysiology behind back pain. There's also varied surgeon provider experiences, meaning that different clinicians will treat patients in different sort of ways, and people will have different experience with the same provider, and they will also have different experiences, obviously, with different providers. There's also a variability in how people respond to the treatment. Already we know that physiologically people will respond differently to certain medications, procedures, therapies, etc. But then there's also different psychological and social demographic factors that make each case of back pain just a little bit unique and different from the last person you saw. So my attempt here tonight is to allow us to kind of understand back pain. So in order to begin to understand back pain, we have to understand the basics of the anatomy. So here are the basics of the spine. You have 7 cervical vertebrae, which correlate with your neck, 12 thoracic vertebrae, which is your thoracic chest region, and then your low back, we typically talk about the lumbar vertebrae, along with the sacral vertebrae, which are 5 fused sacral spine, and then the coccyx, which is your tailbone. The area that we're going to focus on tonight is obviously the bottom of the spine, so that's the lumbar vertebrae, the sacral vertebrae, and the coccyx. Now, this is not something to be memorized, but this is to show that the muscular anatomy of the spine is incredibly complex and varied. And typically when we think of the spine, we think of the bones and the joints and the nerves, but we tend to neglect the muscles, and the muscles make up a large portion of our core and our back. And therefore, as we'll see later, any sort of disruption or issues with the muscle can also lead to the presentation of someone having significant back pain. This is a slide about the bony anatomy, and to break it down, I wanted to talk about just the individual components. So here, this big block of bone you see at the front of the spine is called the vertebral body. We say that there's kind of a roof along the back of the vertebral body, and that we call the lamina. So that kind of serves as a roof to this sort of opening you see here in the middle. The spinous process is the big pointed part that comes out the back of the spine, and that's what you're actually able to feel if you kind of push on your back and you feel kind of those knobs back there. Your transverse processes are the pointed bones that are on the side, which are attachment sites for muscles. The pedicle connects the front and the back of the spine. And now going to the disc sits in between the vertebral bodies and kind of serves as a shock absorber. And so the way I like to describe the disc is that it is kind of constructed like a jelly-filled donut, where the outside of the disc is a more firm and structural layer, and that we call the annulus. And on the inside, there's sort of a more gelatin sort of layer, which we call the nucleus pulsus. So that's how a disc is constructed. And then heading back to some of the bony anatomy, you have what are called the facet joints, which are the articulations of the spine in the back, which actually allows for you to move. So this joint functions just like any joint in your body, in that it is a surface where two areas of bone glide along each other. So again, breaking it down, in the front of the spine, you have your vertebral bodies and your disc. The back of the spine, you have those pointed bones like the spinous process, the transverse processes, and the joints. And then nestled in between all of that are going to be your nerves. Okay. The last part of the spine that we talk about is the sacroiliac joint, which is another joint that sits down by your sacrum and represents where your spine meets your pelvis. And it is also another area that, as we'll see later, can be a source of pain and discomfort. Talking about the neural anatomy, the spinal cord is a big nerve that runs from the base of your brain all the way down to your lower mid back, and that's what allows you to move your arms and legs. The spinal cord, after it ends, it collects into a collection of individual nerve roots we call the cauda equina. Branching off from the spinal cord are what we call nerve roots, which go down to specific areas of your arms or your legs, and allows us to move those individual muscles and feel those certain areas in those arms and legs. Those spinal nerve roots, they exit out of bony windows in the bone called the foramen, and each level of the spine has a corresponding left and right nerve root. We call these the dermatomes, and this just shows that those nerve roots that branch out from the spinal cord go to very specific areas of your legs. Getting down to the naming system, again, we had 5 lumbar vertebrae, so we have an L1, L2, L3, L4, L5, and then corresponding L1, L2, L3, L4, L5 nerve roots that go to very specific areas of your legs. Putting it all together, we have, again, here on this screen, this is the disc. So this picture's flipped upside down, but this is where the front of the spine would be. This is the back of the spine. This is the spinous process here. This is what your facet joint looks like. This is a transverse process. And again, nestled in between all of that is the nerves. So here's just where all those nerve roots have collected in the cauda equina. And this is a sac we call the thecal sac. And then these are the nerve roots that branch off. Okay, and then there's a tunnel here where those nerve roots exit out of, called the foramen. So here on this view, looking at you from the side, you can see this is the window that those nerve roots exit out of to go down to your legs, called the foramen. So why do we feel pain in our back or our legs when something is going on with our spine? So the causes of back and leg pain are, like we said, are variable, and there's a lot of different things that can cause it. But to kind of summarize it up in just a sentence, any sort of deformity or injury to the muscle, disc, bone, or ligaments can lead to painful motion and or compression of nerves and lead us to feel pain in our back or in our legs. The symptoms of back and leg pain are, again, variable. We typically define an acute episode as being somewhere less than 4 weeks, subacute lasting for about 1 to 3 months, and chronic pain is anything greater than 3 months. That pain can be either constant day or night, or it can flare up intermittently with activity or just randomly. The pain can also be described as anything from dull, sharp, piercing, burning, or spasming, or electricity sort of types pains. And it can be localized either to the back or it can radiate to the extremity. A definition that you'll hear a lot of clinicians talk about is radiculopathy, which is basically radiating pain into the extremities that also can be weakness, tingling, or numbness. I think the word that everyone typically uses is sciatica, which is pain going down the leg. But the whole concept is the same in that it usually is something that stems from a pinched nerve in the back that leads to symptoms in the legs. Other symptoms that you can experience are decreased endurance during physical activity and an increased propensity to get tired doing the normal activities you usually do. So to break down the symptoms a bit further, we like to localize where the pain's coming from to figure out what the cause of the pain is. And so to start with, we'll talk about axial back pain, which is pain that is localized to the back. This can be caused by any issues with the muscles. It can be caused by degeneration of the discs or those joints in the back of the spine called the facet joints. It can be caused by any instability or slippage of the vertebrae. There's a condition called spondylolisthesis, which you can see down in this part of the screen, where the spine actually starts to slip forward and comes out of alignment a bit. Speaking of alignment, another cause are abnormal curvatures of the spine, such as scoliosis. Fractures can cause back pain, and then tumors and infection can also cause back pain. So these are all things that can cause pain to just stay localized to the back alone. Another common definition or common term that you hear is spinal stenosis. Spinal stenosis is a very broad word that just indicates decreased space surrounding your nerves. This can be caused by either disc bulging or disc herniations, degenerative changes of the spine that can end up leading to bone spurs or abnormal alignment of the spine, and then abnormal motion or deformity of the spine caused by degenerative issues, fractures, tumor infection, or congenital abnormalities. So when you have spinal stenosis, a compression of the nerves, because those nerves are responsible for your sensation and your strength in your legs, you will typically have symptoms that go down specific distributions or areas of your legs. Another thing we talk about often are obviously disc herniation. So everyone talks about slip discs and disc herniations. What is a disc herniation exactly? So we talked earlier about how there is that sort of two-layer build to the disc where it's built like a jelly-filled donut. And so what a disc herniation is when that jelly leaks out of that donut and pushes on the nerves. So the classic presentation of someone with a disc herniation is typically pain going down the legs where that nerve is being pinched by that jelly that's leaked out of the donut. The good news about disc herniation is that 85% of the time, that jelly that leaks out of that donut either disappears or your body learns to live with it. But either way, 85% of the time, people will require no sort of invasive treatment at all and will get better. This picture here on the right shows the stages or the different conditions of a disc, just so we kind of understand how a disc is, because a disc acts kind of like the shock absorber in your spine, and therefore it is meant to wear down with time, and that is totally normal. And so up at the very top of this picture, you see what a normal disc is. The next picture is a degenerated disc, one that we see that as it ages, it degenerates. A bulging disc is where the outside of the discs push out a bit. So the jelly inside the disc has not left the disc, but it's kind of pushing the outsides out. Typically, a bulging disc does not cause any significant neural compression because, as you can see in that picture, it doesn't really invade into the nerve space as much as, say, the next picture, which is a herniated disc. And you can see there where the jelly contents have leaked out of that disc and are now pushing on the nerves that sit in that space right here. Other things we see is a thinning disc and then disc degeneration with osteophyte formation. As a disc degenerates significantly, the bone loses its shock absorbers, and then the bone responds by making these bone spurs that you see there. And those bone spurs, as we talked about before, can also lead to compression of the nerves. So what are the risk factors of having some of these symptoms? I like to split them up in between fixed risk factors and modifiable risk factors. Fixed factors are obviously age. It's more common as you age, you get more degenerative changes that increase your likelihood of having some problems with your back. pregnancy and being a female in general has also been shown to be an increased risk factor for having back pain. Medical comorbidities such as diabetes, osteoporosis, arthritis, mental health factors such as anxiety and depression. Over on the modifiable side, poor fitness, weight gain, and obesity, occupational risk factors. So that's things like your jobs or the things that your hobbies that you like to do. Are they things that are putting your back at higher risk? Smoking, and then external mental health factors such as stress and jobs. So getting down to diagnosing back and leg pain, what are we as clinicians doing whenever you're coming into our office? The first thing is always a history. We always want to get a proper history and physical, and the vast majority of the time, we are able to figure out what's going on just through that. So with history regarding your pain, we want to know where the pain is at, how long it's been going for, what makes it better or worse. Are you having leg pain that would indicate that you might have spinal stenosis or a disc herniation? Or are you having more mechanical back pain or axial back pain that may indicate that this might be more of a muscular issue? In terms of the physical exam, we want to look at your alignment, what you look like when you're standing. Are you leaning towards one way that might indicate an abnormal curvature of the spine? Do you have any tenderness or pain somewhere? What is your neurovascular exam like? Meaning, what is your strength and what's your sensation? Are you having pain in your legs? And then provocative tests, things that we as clinicians do to kind of cause you to have pain, to see if those things can help lead us to the diagnosis. After doing a history and physical, we look at imaging. So x-rays allow us to look at the bone and just the general alignment of your spine. Here we can tell if you have any significant degenerative changes of either the bone and discs. We can look at that instability or that abnormal slippage of the spine. We can obviously look for fractures. CT scans allow us to also look at the bony anatomy, but allows us to do so in 3 dimensions. And then an MRI allows us to look at soft tissue detail. So X-rays and CT scans are not great studies for us to see the nerves or the discs because those are soft tissue structures. So an MRI really helps us to evaluate the nerves and look for areas of compression. It allows us to look at the state of the discs to see if there's a disc herniation or a bulging disc or a degenerated disc. And it also allows us to look in more detail about other sort of conditions such as tumors. Now that we've talked about why we have back pain and how it relates to the anatomy and how are we diagnosing and evaluating people, I think we can now kind of talk about what the treatment options. So to start out talking about treatment options, we should always start with non-surgical treatment. So the traditional algorithm that most clinicians will use for conservative treatment options starts with activity and diet modification. And this is stuff that you could do before you see a doctor. Just, if you find doing a certain activity hurts, how does it feel if you're not doing that activity? And can you hold off on that activity and see if things get better once you stop? Other things you can do around home are applying heat or ice to help reduce inflammation and maybe reduce your muscle spasms. At this point, you kind of get to the stage where you feel like you need to see a clinician. And so when you come and see us, the first thing we'll do is evaluate you and then see if this is something that is amenable to non-operative treatment. And so we start by typically giving medications to help reduce pain and inflammation, prescribing physical therapy to help you with strengthening and stretching exercises. And then if the medications and therapy don't help, we'll move forward to a more invasive treatment option such as injections, which also help reduce pain and inflammation. So talking about these things further, the medications that I typically start with all the time are anti-inflammatory medications. So these are your ibuprofens, your Advil, Motrins, Aleve, naproxens. Those are the over-the-counter medications you can get. And the thing to remember is that within all of us, we are constantly having some kind of level of inflammation, which is your body's natural response to something going wrong. So if you get a cut and you notice on your hand that that area becomes red and kind of itchy, that is inflammation. So if you have a muscle strain, if you have a disc herniation, if you have arthritis in your back or degenerative changes in your back, your body will kind of sense that as something going wrong that it needs to fix. And so that process that you see that when you cut your hand and you get all that inflammation there, that same thing is going on in your back, around your nerves, in your disc, etc. And so an anti-inflammatory drug basically quiets down that inflammation, takes away some of that swelling and that redness that's around in that area that's causing you to feel pain. So that is my first line medication. Another medication that I give are typically muscle relaxants. So these muscle relaxants are there to help quiet down the muscle, as most people, regardless of if they're having a muscle injury or something related to arthritis or disc herniation in the back, will have some kind of response in their muscle where they'll really feel it seize up or have significant pain. And so these muscle relaxants are there to kind of ease up the muscle and kind of take away some of that pain that you might feel. The second line medications that I'll typically use is corticosteroids, which are a very powerful anti-inflammatory when taken orally, but obviously carry with them some increased risk when weighed up against anti-inflammatories like ibuprofen and Aleve. We also use other non-opioid analgesics such as Tylenol and Tramadol. These can be helpful as well in that they can help you with their pain, but they're not reducing the inflammation in your back, which is the true source of pain. Other medications we use are medications like gabapentin or Lyrica, which are anticonvulsants that can help with ease some of the nerve pain. Antidepressants have been shown to help. And then at the very bottom of the list, I list opioids on here, though I never give opioids acutely for back pain. Breaking down what the goals of physical therapy are is if you walk into a physical therapy office, they're going to start by an assessment and an education. So they're going to assess what your ergonomics are, what your jobs are, how you're doing things at home, and kind of evaluate your body mechanics and help alter those to kind of help put you in a better situation so that you can avoid future incidences. The next thing that they'll do is they'll work on dynamic stabilization exercises and help you with stretching, core strengthening exercises, strengthening the secondary muscles of the spine, including the pelvis and the lower extremities. Physical therapists will also help you by doing manual manipulation, massages, and then functional exercises and rehabilitation as well, where they'll teach you how they'll help you kind of get back to all the things that you were doing before in a safe manner. Again, if physical therapy and medications don't work, the next step that I typically move to in people that are appropriate for this are injection. So if you're having an issue that goes deep into the spine, then the next step is an injection. So what an injection does, or what it hopes to accomplish, is that obviously we want to help you with your pain. So we do include in an injection steroids and a numbing medication. And so there's two medications that we inject into your spine. And the purpose of the numbing medication is that it works fast and it goes away fast. And then the purpose of the steroid is that it takes a couple of days to set in, and then hopefully it lasts longer as a powerful anti-inflammatory. And the reason why we have the two medications is because although we want the injection to help you feel better, we also want to use the injection as a diagnostic tool. So that numbing medication that works quickly and wears off quickly is the diagnostic component of the injection. And then that steroid is a therapeutic component of the injection that will hopefully make you feel better. And so we can inject the medication into a few different areas. If we're going to talk about the nerves, then we want to do something called an epidural injection, which is where we put the medication around the nerves. And the way we can use this as a diagnostic tool is that if we suspect that you're having pain from a certain level, we can inject that level. And if it takes away your pain, then we know that that is where your problem is. However, if you have multiple levels of issues and we inject an area and it doesn't do anything for your symptoms, then we know that it might be coming from another place. Another injection we can do is the facet joint blocks. So we talked earlier about how you have joints in the back of your spine that can move and can become arthritic and degenerative. We can actually numb up the nerves by those facet joints. And if that takes care of your pain, then we know that your pain is coming from those facet joints. The next step from there is we can actually do radiofrequency ablation or rhizotomy, which is where we basically burn or eliminate the nerves over the joints. So the joints still move and they're still arthritic, but you no longer have the nerves there to tell you that that place hurts. And so that's a very effective tool that we can use to help people with pain related to the joints. You should know that the nerves do end up growing back. So it is typically something that needs to be repeated, but it's been shown to be very helpful. Lastly, we talked about the sacroiliac joint and it being a source of pain as well. And you can do numbing and steroid injections into the SI joint itself. Other non-surgical treatment options that have been studied are massages, spinal manipulations with a chiropractor, acupuncture, yoga, Pilates, Tai Chi, aquatherapy, lumbar traction devices, bracing, and psychological therapies. These have all been studied extensively by spine surgeons, by primary care doctors, by physiatrists, everybody. And what we find is that they help people and are certainly worth evaluating, but it has not shown the same success with treatment as the physical therapy and the medications and the injections. But people always ask me, would this be helpful? Would that be helpful? And they refer to something from this list. And I always tell them that the literature shows that it has helped many people. It hasn't necessarily helped enough people to where we recommend it for everybody, but in people who are struggling with therapy and medications alone and want to avoid invasive treatment options, these are perfectly viable options. Other non-surgical treatment options are dry needling, which is where small needles are injected in a muscular area that seems to have issues healing. And by injecting needles there, we stimulate blood flow and thus healing. Electrotherapy uses electrical current to stimulate nerves and muscles. There's various types of this. This has also been found in the literature to be helpful as well. Diathermy basically creates heat and is thought to stimulate blood flow, which increases metabolism and also increases healing. You can apply this heat by microwave or by ultrasound. And then low-level laser therapy is a similar concept to the diathermy, only it doesn't use heat, but it actually uses non-invasive light to penetrate into the tissues. And again, hope to accelerate your tissue repair, stimulate blood flow, and increase healing. On the horizon, things that have been studied that have not necessarily yet been shown to be helpful in humans, but have been shown to be helpful in animals, and we're still doing the studies on, are adult stem cell therapy. So stem cells are precursor cells in your body that have not yet fully divided and fully specialized into what they're going to do, and therefore can turn into anything. And so we looked into taking stem cells and injecting them directly into an area such as the disc, where the disc is worn down, and tried to see if that precursor cell can turn into a disc cell. Because normally the disc material that wears down, it does not grow back. So the hope is that in the future, we can take stem cells and actually grow new disc material into people's disc. For now, we have not noticed that it has provided significant results in humans, but we're still working on it, and the studies and data are still coming out for it. Another non-surgical treatment option that is being studied significantly is platelet-rich plasma therapy, so PRP. So if you look at the breakdown of what's flowing through your arteries and veins, you have blood, but blood is composed of 55% of plasma, 41% of red blood cells, and then 4% of white blood cells, and a smaller percentage of that of platelets. And so your platelets, as if you remember from science class, is what kind of clots and prevents you from bleeding. But we also find that they have significant growth factors and can actually help with healing. And so what we do is we take your blood and then we spin it down and isolate just those platelets, which now that you've spun down just the platelets, you have this high concentration of these platelets that have the growth factors that can help you heal. That then is injected into an area that we think is causing you pain, and then hopefully we can stimulate increased healing in that area. This has been shown to be fairly useful or helpful or has good results with dogs and canines, but so far we have not seen those results translate to human populations yet. But again, just like with stem cells, it's something that we're researching and something that we hope in the future can play a large role in conservative non-operative management. So now that we've talked about the non-operative treatment options, we can move forward to the last line of treatment, which is surgical treatment options. Okay, so surgical management is recommended if your symptoms don't improve with conservative treatment options. The goals of surgical treatment at the end of the day is to either remove pressure off neural structures that are causing you pain in your back or your legs, eliminate abnormal motion and movement that's causing your pain, or restore normal spinal alignment. The two main things that we as spine surgeons do is we either decompress the spine, which is where we take pressure off the nerve structures, or we fuse the spine, where we stop motion across the spinal segment. So when we talk about decompression, we're trying to take off pressure of the nerve. So we're removing whatever is pushing on the nerves. That can be the bone, that can be the disc, that could be soft tissue, that could be, a bullet. It could be something with a fracture where something's pushing on it. We take pressure off the nerves to help eliminate your pain. A fusion is where we create a biologically favorable environment, and we put a piece of bone in between bone, and then over time, bone spans that gap, and an area that used to move now no longer moves as it has been bridged across by more bone. And so we do this to stop painful motion, but we can also use fusion as a tool to hold normal alignment. So if someone has bad scoliosis or an abnormal curvature of the spine, we can actually fuse the spine in a normal spine position so that they no longer have their scoliosis deformity. To break down decompression and what we typically do, to take off pressure off the back of the nerves, we take off the lamina, which, if you remember from the beginning of the talk, we remove the bone off we remove the roof off the back of the spine, and that opens up space for the nerve. And then a laminotomy is where we make a small window in the bone, in the part of the lamina, and that takes pressure off a focal area of the spine. So the difference between a laminectomy and a laminotomy is that in a laminectomy, you're pretty much taking the entire roof off the back of the spine, whereas in the laminotomy, you're only taking off a portion of the roof. At this time, I remember that if anyone had any questions, there's a Q&A box that you can type those questions in, and I will answer those Q&A questions at the end of the presentation. There's a separate box that says chat. That's not where you should put the question and answer or your questions. You should put it in the Q&A box. Sorry I didn't mention that at the beginning. The other way we can decompress the spine is that if the cause of nerve compression is coming from the disc, either a disc herniation or a degeneration of a disc, then we can remove the portion of the disc that's actually pushing on the nerve. So we call that a discectomy. Now, typically, we'll have to make a laminotomy or a laminectomy to access the disc. And typically, we'll only have to take off a small portion of the disc, which is a procedure we call a microdiscectomy. Sometimes it's a large portion of the disc needs to be removed. And if that's the case, we call that a complete discectomy. And in that case, if you've removed the entire disc, we'll actually have to stabilize the spine because you've taken off a large portion of what stabilizes the spine. And so that segues nicely into this next part, which is what is the fusion? So here is kind of what a fusion looks like. So a posterior lateral fusion is where we just approach the spine from the back. And what we do is we lay down some bone graft in between these bones here, which we call the transverse processes. And over time, bone kind of bridges this gap, and that level no longer moves. Then you must be asking, why are we putting these screws and rods back here? And that's because we need to hold the spine still while that bone heals and spans that gap. And so we put these screws through those channels called the pedicles earlier, which links the front and the back of the spine. So these are called pedicle screws. And then the pedicle screws are then linked and connected by these rods, which are then locked into place. Okay, so that's a posterior lateral fusion. An interbody fusion is where you do a discectomy on the front of the spine, and then you put a piece of bone or you put a cage with bone graft in between these vertebral bodies, and then you put the screws in the back to stabilize the spine. And over time, that bone will span the gap between the two vertebral bodies and will fuse that area. So the advantages of the interbody fusion is that we have a larger surface area for fusion, so that increases the rate of fusion. So in conditions where we are a little bit more concerned about alignment and we really want to make sure that the bone fuses, we will typically do an interbody fusion of some type. Now, getting to the buzzwords of spine surgery, nowadays everybody talks about minimally invasive spine surgery. So I felt that this talk would be remiss if we didn't discuss what is minimally invasive spine surgery and what can we offer with minimally invasive spine surgery. So when we talk about minimally invasive spine surgery, or MIS, it is a very broad term that simply describes surgical procedures that are performed through a limited exposure. So what we call classic open procedures, or the way we used to do them before the development of MIS techniques, is that in order to operate on the spine, you had to make fairly large incisions to dissect through muscle to get down to the spine. So as you can see on this picture here in open, you can see that when we dissected down to the spine, we'd have to move all this muscle aside. And so by moving all that muscle aside, it was, spine surgery was incredibly painful, because those muscles, once you manipulate them and have to cut through them, it's very painful. So MIS techniques were developed to minimize that sort of muscle dissection and splitting in that big wide open approach, and we kept it very focal. And so in order to do that, we use special tools and instruments such as tubes and retractors. We use the assistance of X-ray radiographs, fluoroscopic imaging, which is live real-time X-ray that we use in the operating room to help guide our instruments into very specific parts of the spine. And then we also use microscope and special cameras to look directly at the spine. And so we are now able to do significant decompression procedures and fusion procedures through very small approaches, which we call minimally invasive surgery. So the benefits of minimally invasive surgery, or MIS, is that you obviously have a smaller incision and less soft tissue dissection, which we discussed, which will therefore lead to less blood loss, less pain, decreased hospitalization time because of your decreased blood loss and decreased pain, and ultimately a more rapid recovery. These pictures here kind of show comparison of what the incisions used to look like. So in a classic open approach, the incision would run along here to approach this area here, but through minimally invasive techniques, we're able to do two small incisions that are sometimes the size of a dime or a quarter. So going back again to the tools that we use tubes and special retractors, X-ray, fluoroscopy. Other things that you've heard probably are navigation, robotic arms, lasers, endoscopy. So we're going to talk a little bit about these newer technologies that we're now using in our surgeries to help our patients more. So, and I'm going to focus at the end a little bit on endoscopy, which is something I'd like to emphasize and focus on and do. So navigated spine surgery. So what is navigation? So in navigation, we do an intraoperative CT scan that provides us, again, with 3D anatomy of the spine and the bone. And then we use a software that links these images with actual sensors on our operative patient. And then from there, what we can do is use those sensors to help look and see where our tools are going without actually having to dissect down into the spine. So you can see in this top right picture, this is an example of someone putting a pedicle screw. And here they're doing this from all outside the skin and just seeing the trajectory of that screw without actually having to look into the spine. So this allows not only a smaller dissection, but it also allows us intraoperative assurance that our screws are going in the right place. Robotic spine surgery is also something that is being used more often. And when we refer to robotic spine surgery, what we mean is that there's a robotic arm in there that is basically holding the trajectory of our instrumentation, so of our screws and of our bone grafts and things. And it's holding it in the proper alignment. And then it uses nav as well, and connects to that software to allow us to align things properly and holding it. And so it theoretically improves our precision as surgeons. And so this is another way that, our MIS techniques are being improved upon, another way to keep spine surgery safe. Laser spine surgery. So I put laser in quotes because everyone's heard of the laser spine surgery clinic and what they were doing. And, a lot of times what we found was that when they talked about laser, a lot of time it was using electrocautery, which is something we use a lot. But the theory behind it is that you can help use laser or concentrated light and heat to address certain issues in the spine, such as a bulging disc. But more often than not, we use electrocautery or lasers to help us with our dissection down into the spine to help stop bleeding and cauterize things. Endoscopic spine surgery is surgery done with the assistance of a camera via special instruments placed into the spine from outside the body, or what we call percutaneously. So what we are able to do is we are able to put a camera into your spine through a very small incision on your back, and then we are able to visualize directly from outside the body and onto screens that are in the operating room. We're able to look at your anatomy and then use specialized tools to address what we need to. So the concept of endoscopic minimally invasive spine surgery is to provide options that optimally address pathology of the spine, including the disc, without producing the morbidity associated with open surgical procedures. So what we mean there is that it allows us to access the spine without splitting muscle, without having to take too much bone, and allows safe, direct visualization of the spine. Whereas in other sort of MIS sort of techniques, you either have to end up splitting some muscle and dissecting down, you have to remove some bone to get to where you need to go, or you're unable to directly visualize what you're doing. Endoscopic spine surgery kind of gives you the best of both worlds of visualization and minimal dissection. So this is kind of an example of what an open or more traditional microdiscectomy is. So a microdiscectomy is still technically a minimally invasive procedure because your incision is approximately 4 centimeters long, and the muscle dissection is limited to just that small area. But you can see that the incision spans from here to here, and all the way down as you're moving down to this disc herniation here, you're having to move and dissect muscle. We compare that to what it looks like with an endoscopic discectomy or using cameras, and you can see that this incision and the amount of muscle dissection is much smaller, and we're able to go down and use special tools to actually take care of that disc herniation through a much smaller approach. This is a video, if this will work, of what we see as we're working in the operating room. So here, we're actually able to remove the bone and some of the soft tissue that's surrounding the nerve, and we're able to do it looking at it directly. And this was done through an incision that was no larger than a dime. Your wound can be covered up with a Band-Aid. And then, getting to the next slide. And this is what it looks like when that nerve has been decompressed. So here at the top of the screen, you can see that's the nerve there. And now you can actually see the nerve. Whereas in the last view, you couldn't see the nerve because it was being compressed by that bone and all that soft tissue. So this was, again, all done through an approach the size of a dime with no significant muscle dissection. And we were able to visualize the results of what we were doing the entire time. So again, the benefits of endoscopic spine surgery is that we're able to avoid large incisions and muscle dissection. It therefore theoretically leads to less pain, reduced blood loss, quicker recovery time, and it preserves your bony anatomy. We're not removing too much bone in order to access disc herniations. This is a rapidly developing field in spine surgery, and it's a very exciting time to be proficient in endoscopic spine surgery. Newer technologies nowadays are actually allowing us to do fusions endoscopically. So the future of endoscopic spine surgery, I feel, is very bright, and is certainly something that should be used as a tool in spine surgery. Other surgical treatment options that we haven't talked about are lumbar disc replacements and interspinous spacers. These are all meant to be motion-preserving alternatives to lumbar fusion. Lumbar disc replacements are not yet FDA approved, but what they are is that when we do a discectomy or when we remove the disc, instead of putting a piece of bone graft in between the vertebral bodies, we actually put a metal and plastic component that allows for motion. And therefore, you preserve your motion, and theoretically, you prevent wearing down of the levels above and below where you operate. Interspinous spacers are devices that are placed in between the spinous processes in your vertebral body. So here in the back of the spine, they're placed here. And that is intended to keep your spine still in that position and prevent you from leaning back and extending your back more, which we've done studies for and found that when you lean back and extend your back, you are actually closing the space around the nerves a bit. So this device is meant to keep you from extending backwards some. Both of these operations or both of these procedures and techniques have been used for many years. And what we have found is that they do right now have increased reoperative rates. And therefore, that's why they're not necessarily, they're not completely embraced by the spine community yet, but the technology is still being changed and being altered. And so that you may see more of them in the future as we kind of perfect the technology behind them. The last surgical treatment option that we haven't really discussed is vertebral augmentation or vertebroplasty or kyphoplasty. A specific injury of the spine that we haven't talked about are compression fractures. So what a compression fracture is when you get a load to the spine that actually causes the spine to get smushed. And so when the spine gets smushed, for the vast majority of people, it smushes and it gets smushed and then it doesn't continue to collapse. But for people where the spine is continuing to collapse, they can have significant back pain associated with walking and movement. And so after a course of conservative treatment, of course, and if your pain is still there because the vertebral body is continuing to compress, what we could do is actually put cement into the spine to stop it from compressing any further. And so this is another minimally invasive procedure where we put needles and cannulas into the pedicles using x-ray guidance from outside the skin, and we put it into the vertebral body. And once we confirm that those cannulas and those needles are inside the vertebral body, we can place cement into the vertebral body, and therefore you stop the compression. Kyphoplasty is a variation of this procedure where instead of directly putting cement into the bone, we put a balloon in there first and then open up that balloon, and that helps restore some of your anatomy and also creates a space for that cement to go into. So the risks of spine surgery are the same risks as many surgeries. So we always caution people undergoing any surgery that the risks are ongoing pain, bleeding, infection, damage to surrounding structures. So obviously in the spine, we're concerned about nerve injury because we are working around the nerves. Post-operative deep vein thromboses or pulmonary emboli, these are blood clots. Need for more procedures in the future, damage to any blood vessels in the area, and then you have your risks from anesthesia. What should you expect post-operatively? We've discussed a multitude of different procedures, so the post-operative course is going to be variable depending on what you have done. But as a general rule, most of the time with any surgical procedure of the spine, we want you up and moving and walking as soon as possible. The days of requiring extended bed rest post-operatively are gone. We want people staying mobile and moving. No matter what we do, whether it's a discectomy or a fusion, the goal is to keep you mobile and to keep you moving. The hospital stay, again, is variable depending on what you have done. As a general rule, with most lumbar spine procedures, we don't want you to do any significant heavy bending, lifting, or twisting for the first 6 weeks. Typically, for most of my patients, for the first 6 weeks, I kind of just want you to walk around the house. So because of that, I don't necessarily need you to do physical therapy within the first 6 weeks, but at 6 weeks, when we're starting to increase your activity, then you can start physical therapy. Wound care, we always ask for, if you're smoking, that you quit smoking approximately 6 weeks before surgery, and that you keep that smoking off for 6 months. And then good, adequate diabetes control is vital for wound care and wound healing. In terms of recovery rates, we say it's approximately 6 to 8 weeks for immediate recovery to where you can return to most of your activities of daily life. And then full recovery can range anywhere between 3 and 12 months to where you will feel quote unquote normal. So after reviewing all this treatment, what is the best treatment option? The best treatment option is always prevention. So this could go at the beginning of the slides, but I like to put it at the end. It's kind of a reminder, just so you remember that prevention is always going to be the best treatment option. So we always want to ensure that at home you're using proper ergonomics. So this includes, making sure that you have properly designed furniture and equipment. If you're sitting at a desk for long periods of time, then you should take breaks, avoid sitting for longer than 30 minutes, get up and walk around. If you have access to a standing desk, that's going to be better than a seated desk. You want to maintain good posture. You want to wear proper shoe wear that are comfortable, low heeled, have a good solid insole that provides you support throughout the day so you can minimize sort of the stress through your back. You want to do proper lifting techniques, so lift appropriate weight, don't lift outside your weight class. When you do lift, again, lift with your legs. That means when you are standing up with whatever you're carrying, you're not bending your back, you're actually straightening up your legs. And then you want to keep your objects close to the body and keep your back straight. So keep the object close to the body because as you extend it out, it actually increases that sort of lever arm and puts more stress on your back. So keep whatever you bring up to you, keep it close to your body. And then you want to keep your back straight to, again, avoid bending your back and lifting with your back. In terms of sleeping position, the recommended sleeping position from spine surgeons, spine doctors, is that we'd like you to sleep on your back on a relatively firm mattress. So if you're a stomach sleeper and you're having back pain, try to see how you feel if you lie on your back. How can you lie on your back, or what recommendations do we have to kind of keep you on your back? You can try some pillows to kind of bolster you on the sides to kind of prevent you from rolling in the middle of the night. That's about the best we can do. Other things is obviously diet, proper exercise, and weight loss. As you gain weight, that's just more weight that your spine will see and will accelerate any sort of degeneration you may have on your discs or in your joints. In terms of exercise, we emphasize back and core strengthening, stretch before and after physical activity to make sure that your muscles are at their optimal length and that they're functioning optimally. And then if you smoke, quit smoking. So those are probably the best treatment options there. It just pertains to prevention. But obviously, if you don't, if you're unable to treat yourself with prevention and conservative treatment options, we've discussed the surgical treatment options as well. So in conclusion, we have to remember that if you have low back pain, you're not alone. Low back pain is one of the most common conditions that we see. Numerous factors play a role in the development, and the vast majority of those factors and those causes of back pain can be treated non-operatively. Again, reviewing the traditional conservative treatment options, it's physical therapy, medications, and injections, although the other treatment options we discuss are perfectly viable as well, such as massage, chiropractor, acupuncture. Surgical decompression or fusion of the spine can be a helpful treatment if conservative treatment fails. But again, surgery should always be the last line of treatment for people. And so my hope, is that anyone suffering from back pain can get by without ever having to see a knife. So any patient that we're able to get to pain relief without ever having to operate them is a huge success for us. Okay, so that's my talk. So at this time, I'll be addressing the questions and answers from the Q&A box. You can still ask questions now if you would like. Okay, so the first question I have is, can fusions cause long-term problems? Yes, and so the answer to that is yes. So whenever, this kind of gets into the biomechanics of the spine, but we were born with every segment of the spine moving. So when you stop, so anytime you bend, jump, move, all of the energy and forces that are being distributed to the spine are kind of being absorbed equally by all of the levels that move. And so when we fuse the spine, you are now taking away a level that typically absorbs force and pressure as you bend and jump and move. And so what fusions can cause is something we call adjacent segment disease, which is where the levels either above or below the fusion start to break down and wear down. So that is a known issue with fusion. And that's kind of the biggest long-term issue we see with fusions. Otherwise, once we fuse a level, that level has been managed. So if you had some kind of nerve compression or something like that because of an area that was moving a lot and you fuse that nerve at that level should now be okay. And just a reminder, if you're hitting the hand raising button and you have a question, please type out the question in the Q&A box and I'll answer it as I come along. The next question, percent success of the various surgical procedures. So any surgical procedure we do, I wouldn't take it on and I wouldn't recommend it if we didn't have at least a 90% success rate. And also, when we get into success rates, we have to talk about what success is. So I will say that surgery for things like surgeries for things like back pain, uh, speaking honestly, as spine surgeons, there's so many causes of back pain that we still have not really ironed out what can go into back pain. So when it comes to fixing back pain with surgery, those percents are less, anywhere between 50 to 75%. But when it comes to helping you with pain in your legs, we have a pretty good idea as to how to help you, because when you have leg pain, we know that it's because the nerve is being pinched. And so we know that if we take pressure off that nerve and make it so that it's not getting pinched anymore, that will take away your pain. So with those type of procedures where we're doing surgery to take away leg pain, any of those procedures I discussed, we would expect at least a 95% success rate with those surgeries. Okay. And the next question is MIS used to do fusions? Yes, we talked about that. And we talked about how endoscopic technologies are being utilized now to do fusions. But also, again, MIS refers to minimally invasive surgery and describes a very, very broad category of spine surgery. So, any fusion that we do where we're trying to minimize how much we're dissecting is considered MIS. And yes, we do plenty of MIS fusions. The next question is, how does IBS affect back pain? What can be done to correct the pelvis that is out of alignment? Can you talk more about diet, any foods to avoid? What about turmeric as an anti-inflammatory and other homeopathic treatments? Okay, so let me break down this question. So how does IBS affect back pain? So directly, I'm not aware of IBS directly affecting back pain, but I know that there's a large population of people who have IBS who have other sort of pro-inflammatory sort of conditions in their body that predispose them to having increased rates of back pain. Sometimes that can be, related to kind of rheumatologic factors, or sometimes it can be related to other issues in the blood. But in terms of direct effect with back pain, I don't think IBS necessarily causes back pain. I think the things that make you more prone to having IBS can also make you more prone to back pain. That at least is my understanding of it. What can be done to correct a pelvis that is out of alignment? So I can do a completely separate talk about lumbar alignment and pelvic alignment. It's a very complex topic, but you have fixed parameters with your pelvis, and you have variable parameters with your pelvis that can lead to it being out of alignment. So words that you might hear if you do a lot of research into pelvic alignment are things like pelvic tilt, pelvic incidence, and sacral slope. So out of those, again, this can be an entire talk, so I don't want to bog you down too much. But out of those three components that we talked about, pelvic incidence is sort of a fixed pelvic parameter that we look at to look at the pelvic alignment, and that can't really be corrected. But things like pelvic tilt and sacral slope, those can be corrected by doing things that affect your posture, by stretching your hamstrings. Sometimes those can be out of alignment because of issues with your back, if you don't have enough curvature in your back. And so addressing those secondary issues can thus help your pelvis kind of correct its alignment a bit. But again, certain parameters like pelvic incidence, that's just kind of your pelvic's natural bony anatomy, and that can't be changed. Talking about diet and any foods to avoid. Again, so this is kind of more delving into more the homeopathic treatment options, which I'll admit I'm not the most well versed in, but we talk about the superfoods and those foods that kind of cause decreased antioxidants, that decreases oxidation and stuff like that. So like blueberries and avocados and things like that. I think, the literature, the data on that so far has kind of been 50-50 on whether or not the specific foods help. I think what's more important in regards to your diet is that you have a healthy diet that allows you to maintain your fitness, and allows you to kind of maintain a proper weight. I think what hurts the spine more often is going to be things like rapid weight gain or obesity, as that puts more load and pressure on the spine. In terms of turmeric and anti-inflammatory homeopathic treatments, again, in the spine literature that we read and in our articles, that stuff has been shown to be 50-50, meaning that it's helped. We've noticed it helps people. It certainly doesn't hurt people, but it doesn't help people enough for us to say that everybody should do it. You should all spend the money for it. But you talk to plenty of people who will talk about how they felt significantly better after it. So in people that ask me, what should I take? What should I eat? Turmeric is certainly on that list. Next question, can you do MIS for spinal stenosis that goes over 2 or more vertebrae? Again, kind of answering this question, MIS, again, is a technique. It's a technique that we can use for any procedure of the spine, as long as our goal is to minimize how much dissection we're doing and we're using special instruments and tools. The quick answer to that is yes, we can. We can use special retractors, tubes and smaller retractors and approaches that avoid dissecting too much muscle, and we can relieve your spinal stenosis from that. Okay, what is your opinion of what is referred to as the Veriflex procedure, where an object is placed in the spine to open up the spine to give more space for the nerve? This is referred to as minimally invasive and outpatient procedure. Yes, so the Veriflex procedure, this sounds like one of the interspinous spacer tools that we were talking about towards the end of the talk, where you place something in between the spinal processes, which prevents you from extending too far back. I think this is a good procedure. It's certainly very, very minimally invasive and can be done very quickly. I think nowadays certain people can even do this in the office and not have to take you to a surgery center or the hospital. Conceptually, it makes sense. And again, the reason why it makes sense is because when someone has spinal stenosis or closing in of the nerves in the canal of the spine, that canal is opened up whenever we bend forward. So whenever someone has spinal stenosis, what we classically will see is that they're leaning forward a lot because they feel more comfortable walking that way. Or so if you see them at the supermarket, they're kind of leaning over their shopping cart. That's because when they lean backwards and when they stand straight up, they're closing the space for the nerve. So these interspinous spacers like the Veriflex, that's what they're there for. They're there to prevent you from extending too far backwards. So I think that it works, but what I've seen is that they do require high reoperation rates, meaning that if it's effective, it doesn't remain effective for very long, and eventually will need to be removed. The next question is, how long can you safely use NSAIDs? So this is a very good question that I didn't get a chance to address, but yes, we as orthopedic surgeons and spine doctors, we love our NSAIDs and our anti-inflammatories because they're great at reducing inflammation. Like any other medication, they do have their long-term side effects. The most common side effect that we typically see with NSAIDs is gastric upset or stomach problems. And so we don't recommend them for people who've had GI ulcers. And if you take them for long periods of time, you can end up developing stomach problems. The other issues that we see with long-term NSAIDs are kidney issues. And then certain cardiologists in the community also do not like them because they can also kind of thin your blood a little bit and interact with some of the other cardiology medications. So what my typical recommendation for NSAID use, for safe use of NSAIDs, is that you take it for about a week or two at a time. And so NSAIDs, again, are not painkiller medications. They reduce inflammation in your body, so they work better when you have a baseline level in your system. So in order for you to maintain a baseline level of anti-inflammatory in your system, you need to take it a little bit more frequently and almost like a scheduled medication. So what I recommend is you take it like a scheduled medication for about a week or two. And after taking it about for a week or two, you should rest for a few days to a week. And that allows your body to eliminate it from its system. It allows you to prevent having that gastric upset. It prevents you from having sort of long-term kidney issues. You rest for about a few days to a week, and then you kind of reevaluate. If you're having pain again, or if the symptoms are still not improved, you either try it for another week or two, or at this point, we talk about more invasive treatment options, or you see your spine surgeon. If you feel fine though, and the pain has been gone, then you don't have to take the medication. And then you kind of wait for the next flare up of pain if it comes at all. And so if pain comes back, then you again repeat that cycle of 1 to 2 weeks, rest for a few days and reevaluate. So that's kind of how you safely use NSAIDs and avoid some of those side effects. Next question, what is your opinion? What is your opinion of spinal cord stimulation? So my opinion of spinal cord stimulation is that it works in very selective groups and populations. And so what spinal cord stimulation is, it's kind of the last ditch effort for someone who we've tried obviously medications, therapy, and injections. We've tried the whole gamut of non-operative treatment options. And then when we look at your MRI and your x-rays and your CT scans, we don't necessarily see something that we can help with surgery, but we don't know exactly why you have back pain. So in these situations, we hypothesize that there's something with the nerve conduction in your spine and in the nerves of your spine that simply is off. That's just simply not allowing you to live comfortably without back pain. And so in order to modulate that sort of nerve signal, we place spinal cord stimulators on the spinal cord itself. And so my opinion of these is that for very selected populations, they work. And so the process behind getting a spinal cord stimulator is that you'll have to go through, obviously, the gamut of conservative treatment options. You'll have to be ensured that there's no surgical treatment options that can help you. And then once that's done, you'll have to go through a series of tests where certain areas of the spinal cord are actually tested to see if that eliminates your pain first. And if after that test, you find that, yes, that pain went away when you stimulate that area of the spinal cord, we'll put a spinal cord stimulator, which kind of gives this constant sort of low-level electricity signal that modulates sort of the signaling of the spinal cord and hopefully eliminates your pain. So that's my opinion of spinal cord stimulation. That's what it does. I think it can be very helpful for the right people, but the amount of people that actually need them is fairly limited. Next question, can I get a copy of the slides? I'm not sure. I think that this is being recorded and might be shown for somewhere, but let me talk to Kathy after the presentation to see if there's a way or a form we can do it. And if it is possible, we'll make them available, and then you and her can communicate to find out how you can get a copy of them. Okay, I believe you said 85% of herniated discs resolve on their own. What if we're in the unlucky 15%? How long should you wait to know if it will/has resolved on its own? Is endoscopic surgery recommended? How do you determine if this should be performed? Fantastic questions. Okay, so what if we're in the unlucky 15%? So people within that unlucky 15% will typically get injections in the hope that that will kind of reduce their pain enough to where they can tolerate it and hopefully buy them some more time for things to resolve on their own. How long should we wait to see if it will resolve on its own? That's actually a tougher question because everyone kind of has their different preferences and also different presentations. So people with weakness because of disc herniation, meaning that that nerve is being compressed to the point where you actually have weakness in your leg, I would say that you shouldn't wait longer than approximately 6 to 12 weeks, just because we know from our studies that the longer you leave weakness alone and don't address the cause, the increase your chance of having that weakness be permanent. So even with surgery, it doesn't go away. So in the situation of weakness, we tell people, give it about 6 or 12 weeks, and if it doesn't get better with medications, therapy, and injections, we should talk about surgery. Now, if your symptoms are pain, numbness, or tingling, then that doesn't necessarily affect your function in the same way that weakness would. So if the symptoms are pain, weakness, and numbness, then we kind of tell you that you could, as long as you can tolerate it, if you feel like you can live with it, you can wait as long as you want. But you should know that the longer you leave it, the more likely it's not going to resolve on its own. So some people have a very low threshold for wanting to do surgery. Like they say that they don't want to live with this for longer than 6 weeks. So at the 6-week mark, we'll do the surgery. Other people are really, really opposed to surgery. And so they'll wait years and years and years to finally do it. And then we'll do the surgery. Both groups will typically resolve if their symptoms are pain, numbness, and tingling. Weakness, again, is a different sort of animal. So if you have weakness, you should think about having it done sooner rather than later so that your overall function is not changed. I hope that answers that question. It's a bit complex. Is endoscopic surgery recommended? Yes. And so Endoscopic spine surgery is recommended not with every single disc herniation, because once you kind of get down into the anatomy, certain levels of the spine are difficult to access via an endoscope. Um, and certain disc herniations, based off their location, might be better off with a traditional microdiscectomy, which again is a 3 or 4 centimeter incision that's in the midline. So whether or not it should be performed is typically based off of your anatomy and the actual pathology. But for certain disc herniations that are kind of out to the sides or are small and localized, an endoscopic discectomy is a fantastic treatment option and tool. Next question. After 3 years of SI injections for spinal stenosis, steroid injections for spinal stenosis with no longer help, what is the next option? So, at this point, if you've exhausted injections and all conservative treatment options, if those injections did help you for a certain period of time, we would say that you would be a good surgical candidate, because at this point you showed that by doing the injections and seeing that they help, it kind of confirms that diagnostic component of the injection where yes, this is where I hurt, this is where the pain's coming from, and what we're seeing is that even though you're doing the injection to take away the pain, it's not affecting or changing your anatomy enough to help you. And so in those situations, the next step would probably be to change the anatomy. And the way we change the anatomy is through surgery. So depending on what causes the spinal stenosis itself, I would say that the next treatment option that I'm trained in is surgery. But obviously, if you are functioning well and if you're opposed to surgery, then you can look at some of the other conservative and non-traditional treatment options we talked about. I'm just not aware of them helping significantly at this point. Okay, so I hope that answered your question. Next question, are there any risks associated with injection for the facet joint issue as well as epidural for potential disc issue? So with, incapable hands, the risks for both of these are fairly minimalized. Obviously, you're putting a needle in the back where the nerves are, and so the potential for nerve injury is there, especially with the facet joint, because you're kind of going in the area where that nerve root branches out. But again, we're using fluoroscopic or live x-ray to kind of guide the needle the entire time and making sure we're going into the right spot. And we also have tactile feel, so we know when we're in the right spot too. So with the facet joint, there's a small risk of injuring the nerve root. But again, most of the time you're awake for this. And so if we're getting anywhere close to the nerve, you're feeling it. So we would never inject medication directly into the nerve because you would feel us when we're poking that nerve. And so we would back off and make sure we're going to an area where you don't feel that pain. The same thing applies for an epidural injection. We're again injecting around the nerves and not into the nerves. If we're injecting into the nerves, you would report something as we're injecting or as we're getting close to there. And so you would let us know. So the risk of nerve injury is minimized by the fact that you're awake and you're telling us how you're feeling. The other risk with an epidural injection is a spinal fluid leak. So again, when we talk about the nerves and how they're sitting in a sac, that sac is filled with spinal fluid. And so if we're putting a needle in there, there's always the risk that we put a hole in that sac. If we put a hole in that sac, that fluid starts leaking out. And if that fluid leaks out enough, you can get a small headache. And so when that happens, we ask that you kind of lie flat until that headache goes away. It eventually stops leaking and closes off and everyone does fine. So that's the only other risk with epidural injections. The other risks, obviously, is that with injection of steroids, there's risk from the steroid medication. So that could be, that could affect your glucose levels if you're diabetic. It can potentially make you uneasy or anxious because of the mood effects of steroid. That is very rare because we're not injecting the steroid into your bloodstream, we're just injecting it locally. And then it can also cause some discoloration of the skin. Any risk with rhizotomy? So a rhizotomy, the procedure of rhizotomy is almost identical to the facet joint injection. And so the same risks that are with the facet joint injections apply with rhizotomy. Next question, please discuss issues and treatment of coccyx pain. Okay, so coccyx pain is something we call coccydynia, and I didn't talk about on our slide because the treatment options for it are not that great. So coccydynia is again, pain of the coccyx. So the coccyx is, again, that tailbone, the very, very end and tip of the spine. And you can get coccydynia from a variety of different issues, including any sort of trauma or injury, fractures or breaking of the coccyx, or your lifestyle that might cause you to have to sit on it for a long time. The treatment options for it starts with, some therapy for some pelvic strengthening exercises, anti-inflammatories, like we talked about. The thing that I found that helps the most is very, 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 very religious use of a donut that offloads the coccyx. So we're not talking about just sitting on a cushion. What we want is an actual donut or something that's cut in the middle, because your coccyx will kind of float in there. What you want to do is take pressure off the coccyx, because most of the time the problem is not with the coccyx bone itself, it's with the tissues and the muscles and the ligaments that are around the coccyx. And so those tissues need time to rest. So offloading those with very, very, very good use of a donut or some kind of offloading pillow is the best treatment. If those things don't work, then you can do injections, and ultimately you can do a surgery where you just remove the coccyx. It's very, very rarely done because it has a very high complication rate with infections and things like that. So I don't typically do them. Number one, because I really, really try to avoid it. And number two, because it is rare for people to get to that point where they actually need it. Okay. Next, and the last question I have is, what is the best way for a doctor to determine if pain is mostly due to low back pain or the SI joint? How is SI joint issue diagnosed? Fantastic question. So the best way is through your clinical physical exam. So there's certain maneuvers, provocative maneuvers that we can do during the physical exam that stresses your SI joint that could tell us whether or not your SI joint is the issue. Other things that we use to help diagnose it is also MRIs and x-rays to see if there's any pathology in the SI joint. And the last and probably most direct way to diagnose SI joint issues are through injections. So if we do an injection of the SI joint and your pain improves, then we know the pain is coming from the SI joint. Talking a little bit more about the SI joint, because I know we glossed over it because I didn't want to take too much time with the talk. But SI joint issues, the way they're managed is, again, therapy, medications. If that doesn't work, injections. If the first injection works, then you should get another injection. If that second injection works, but then your symptoms return, then we can do a fusion procedure of the SI joint. That's a minimally invasive procedure where we basically put cages across the SI joint and then stimulate bone growth across the SI joint and fuse the SI joint itself, okay? But again, that has to fail 2 injections. That's the FDA mandate, okay? Another question, follow up on the rhizotomy question. Any loss of mobility after, would movement be affected? Quick answer to that is no. No, because if anything, your movement might improve with the rhizotomy because you're no longer having that pain theoretically from the movement of those joints. So you actually should have increased movement. Now, over time, remember, you're doing rhizotomies because you're having arthritic degenerative changes of the facet joints. And over time, the facet joint arthritis and degeneration, it's just going to progress. And it might progress to the point where, yeah, your mobility will be limited. But the mobility being limited is not due to the rhizotomy itself. It's more due to the natural progression of the degenerative changes in your spine. I hope that answers that question. I have a question for, I have all night. So if you have questions, keep bringing them in. As long as you're here listening, I'll answer them. How long do you have to wait between injections? Can multiple injections cause other issues? Thanks. Different clinicians will do it differently. Some people will wait a couple of weeks in between injections, but the general rule is that you don't want to exceed 3 to 4 injections in a year. So if you want to space out your injections to allow you to kind of preemptively be okay in the wintertime or something like that, if it's currently spring, then what we'll do is we'll wait 3 months or so between injections. But if you feel like this is an acute issue and you just really want to eliminate it and you can't deal with pain right now, then some people will have you return after just a couple of weeks to repeat the injections. Can multiple injections cause other issues? Well, the reason why we don't do them more than just 4 times a year is because if you have too much steroid kind of in that area, it can start to affect the soft tissue health in that area, and can cause like increase, breakdown of the soft tissues in the area. It can decrease bone strength and things like that. So that's why we don't do it. But as long as you keep it within that 3 or 4 times a year, you should be fine, and those multiple injections should be okay. Thank you. Okay, well, that was the question. Okay, so does anyone else have any other questions at this time? All right. I'll take that as no. Well, thank you everyone for being here tonight. The contact information for my office is there. If any ever have any issues, my email is there. I'm always willing to answer emails if you have any other questions you can think of. But yes, thank you everyone. Have a good night. Everyone stay safe out there. And thank you again, Kathy, for all your help tonight.